Good morning. Good morning. All right, you're welcome to today's lecture. Today, we will take a look at AUM 221. We are still discussing routes of drug administration. In our last lecture, we concluded with the enteral route of the systemic route, right? So today we go over to the parenteral route of the systemic routes of drug administration. And I can remember vividly that we route under parenteral route. We started with the main routes that are under the parenteral routes, which are the injections, the injection routes. The injection routes are the main ones that is under parenteral route of the systemic route of drugs administration. Then we have other ones that have both systemic and local, or even though those ones they are more systemic, they are more local than systemic. The route like inhalational and the intranasal. Hope you can remember. Inhalational and intranasal. Inhalational and intranasal. So those ones they have both, but mainly, in fact, there are some textbook you will see, you will not even see them under systemic. Am I communicating? You see them more. They have more effect in the more effect locally. Okay, so let us now look at the ones that are the major ones that have systemic effects. The parenteral that have more of systemic, that are mainly systemic effects. They are under the injection routes. Okay, we pick them one after the other. The commonest among them is the intravenous. Intravenous. So let's look at the intravenous routes of drug administration. Please, who has this phone? I would like to make use of this. Yeah. Give, please. Help me draw this circular. Continue. Ask your question. Feel free. Yes. What? Sorry. Yes. It's injection. Yes. We have many injections. We have intravenous. We have intramuscular. We have intra-arterial. We have intra-articular. There are many of them. We have intradermal. With the aid of injection, you can do administer those ones. Anyone that you can administer with the aid of needle. Am I communicating? Is under injection route. Subcutaneous is there. Subcutaneous is there. Once you need a needle, whether it is going deep into the dermis, whether it's entering the vein, the artery, the synovial cavity, the spinal cavity, right? Whether it's entering the Anyway, it's empty. So why he needs what? A needle to be able to administer it is what? Under what? The injection what? Route. So we'll take them one after the other. We'll take them one after the other. Okay. Hope I'm not out of the frame. Am I? Good. Now, so let's start from the what? The intravenous. Even in your first year, I told you that intravenous route has 100% what? Bioavailability, right? Remember that. It has what? 100% what? Bioavailability, because that is, in fact, other ones may waste time before they enter the what? Systemic circulation, right? But intravenous is entering directly into the vein. Even intra-arterial is entering directly into the blood vessel. Hope you know. Okay, we'll take them one after the other. So by the time we get to the intra-arterial, you understand what I mean, what they usually use. So let's start with intra what? Venous. Now, intravenous can be given in two ways. We have the one we call bolus. Bolus. From Greek word bolus. It's bolus, but from Greek word bolus, meaning what? Lump. What it means is that you infuse the whole thing at once. Am I communicating? Am I communicating? Yeah. You inject, but we have the one that takes, you infuse slowly over what? Time. Okay, slowly over what? Time. In one of the superficial veins. Please note this: intravenous is on the way. Superficial vein. That's why if they want to inject you intravenously, they will sometimes they'll beat your back of your palm. Two of us, they want to see what? Vein. If they don't see any vein, sorry, they will not be able to inject you intravenously. Are you aware? Are you aware? If the nurse find it difficult, or the doctor find it difficult to see any vein, any vein, they will not be able to do what? Inject you intravenously. That's the main point you should note. Is are the what? Superficial what? Veins. Please note that. So now, another thing I want you to understand here is that intravenous injection, when compared, by the time we do intramuscular and subcutaneous, you understand, when compared with intramuscular and the subcutaneous, they are more difficult to do what? Administer. Am I communicating? Do you know why? Do you know why? You need skill. It's not what anybody can just do. You may if you're not skilled in doing it, you may inject it in the wrong place. Hope you know. And it will cause what? Issues. So you should be able to even to identify the vein. You should be able to do what? Even handle the patient to be able to do what? Administer what? So it's more difficult to compare with what? Subcutaneous and what? And what? Intra what? Muscular injection. And when the person is obese, is that always an issue, serious issue. Try to do what? Inject what? Intravenously, because you start looking for what? Veins. Are you aware? The fat will fill everywhere. Two of us, you start looking for what? Veins. Okay. Now I have already told you that in intravenous injection, that the drug is administered directly into the what? The systemic circulation, in the bloodstream. I've mentioned that, right? Okay. Now, of course, the effect is what? Almost is quickly. As it is entering, the effect is faster. In fact, it's the fastest. The fastest onset of what? Action. That's what? Intra what? Venous. Okay. But there's an issue there. Please, this one needs close what? Monitoring. Intravenous needs what? Close monitoring. You don't just be doing it and be doing what else you want to do. You should be careful because of what? You check, because of the signs, you be able to check signs of if there's any issue. You stop, even though yes, you cannot take back what has entered the system. Unlike oral route, where if you ingest and there's something, you notice something, and you can stop, or you can even induce what? MSCs, true or false, for the patient to do what? Vomit. I can even activate charcoal to mop it up. Am I communicating? You see her face. Okay, you know how to activate charcoal. Charcoal. You call charcoal, right? You have not. Okay. Yes, it's also yes. You can use it to do what? It absorb poison, even poisons in the what from the what stomach. Yes, you can do that. Yes. But unlike oral route where you can do this, but injections through intravenous, you will not be able to do what do that. So that's why you be careful what you are injecting. Be sure of what you are doing, and also be careful of to check for any effect on the patient as you are doing it. You want the patient closely and be able to see if there is any issue, so you can do what. That's why it's even advisable to slowly do it. Okay, to slowly do what, do it. Yeah, ask. Mama. Don't worry. By the time I have mentioned, I have explained to some extent. By the time we do intramuscular, you understand better, okay? Okay? All right. So, now, the effect of the drug by this intravenous route is what? Does not last for a long time. Just the effect lasts for what? Short that time than others. So that's why it's always good to do what? To infuse it what? Continuously. Okay? To infuse what? Continuously. So as to keep the effect what? Constant. So as to keep the effect what? Constant. So the issue of when the toxicity is there, the issue of what toxicity, when there is an issue, you find it difficult to do what? Retract, okay? By the time we do it, as you understand this point better. Now, explicitly, I want to say something. I want to point out, be summary or whatever, of the advantages and what? Disadvantages. So, now, of course, advantages, it has quick onset, true of us. Quick onset of what? Action. So you can use in emergency what? Situation. True of us? Good. That's summary. Then second one is that it has high what? It had highest what? Bioavailability. It's 100 what? Percent bioavailability. Of course, the first pass effect is not there. It bypasses what? The drug administered through intravenous bypasses what? First pass what? Effect. But the drug doesn't get to what? The liver, through of us, or the portal circulation. It doesn't get there. So it bypasses what? First pass what? Effect. These are the advantages I'm listing in summary form. I'm explaining what I want to explain. Just in summary. Now, of course, in intravenous, large volumes of fluids can be what? Administered. True of us, large volume can be what? Administered. Because intravenous is not only use what? Injection. You can also do what? Infusion. Hope you know. Of course, in infusion, you can have what? Someone can take up to 500 ml, 1,000 ml in a day. True of us. So large volume can be what? Administered. Okay. Of course, drug that agitate or irritate the gastric mucosa can also be administered through this route. True of us, because it doesn't need to get to the what? The stomach. Good. Now, for this particular, I think I mentioned this point I want to make now. That if a patient is unconscious and vomiting, you don't need oral. True of us, such drug can be administered what? Intravenously. There is no drug-food interaction. True of us? Why do you think so? Yes. Yes, true of us? Yes, because there's no contact with the food you do what? Eat. Hope you know. Good. So, but it has its what? Disadvantages. It has its what? Disadvantages. Is it painful? So it's painful. It's painful, and because another point is that it requires sterile conditions. Yes. It requires sterile what conditions. So you should of course, you know the reason is entering the bloodstream directly to avoid sepsis. To avoid what? Sepsis. Is entering directly to avoid what? Sepsis. So it requires what? So I'm trying to keep sterile as safety conditions. Is not be here. Two of us. It's difficult. It's stressful. Two of us. Try, even though it's good, but it's not that simple. Two of us. So if there is, and if you can administer that such drug through another means and get the result, why are you passing through that stress? I'm not getting good. So you go straight and use the one that you can. All right. So of course, the skill and technical assistance is required. It's not what anybody can do. Two of us. Good. You must be skilled. And since you don't have the skill, you have to pay for the skills. Two of us. Skill, yes, skill. Technical skill is what required. Do you know why you pay more? If you like now, if you want to take paracetamol as a drug, do you know why you pay more taking it as an injection and taking it as what? Tablet. Which one do you pay more? Injection. Because you pay for the formulation itself. Then even pay for the person that will do what? Inject. Because it's a scale. The person that acquired that scale. You pay for service. Two of us, you will pay for the what? Service. Because you don't have a scale. You don't have a scale, you pay for the what? Service. So you require technical skill. It's not what you can be, you just carry and be jigging in your house. Hey, how far now? You just put tablet in your mouth and drink water. No. If you cannot do it, you pay for it. Just like some of you now that know how to plait here. If those that cannot do it, we pay for the what? The skill, because you acquired it. Two of us, unless you want to do what? Charity, right? Unless you want to do what? Charity. So instead of spending money and wasting your time, you just do what? Cut your hair and go your way. Cut your hair, go your way. See how much, very, very simple. In the morning, just go her way. No time for long. Just take home, and go her way. No stress. Mama was in that league before, but she changed. They converted her. See, Victoria. Very simple. Simple. All right, let's continue. Okay. So I think the disadvantage I want to say now, I have mentioned it before, that unlike GIT drugs, where you can easily, are we together? Yes, unlike GIT drugs, or unlike in GIT, unlike oral route, better, drugs cannot be recalled by strategies such as emesis or activated what? Charcoal. Okay, drugs cannot be what? Recalled through what? Strategies like what? emesis and what? Maybe if you notice any adverse effect or that the patient is not reacting well to it, you will not be able to do what? Recall it. Unlike the one you take, you can induce emesis, person vomit immediately, or you give activated charcoal to mop it off. But this one, you can, emesis is EM. Emesis is EMESIS. That's why we are the way it came from. Emetic, drug emetic. Don't worry, by the time we do, okay, that should be a second semester. It's limitation, yes. It's limited because you cannot recall if you are if you notice such issues in patient, you cannot recall it back. So it's a disadvantage, two of us. It's a disadvantage, not true. And you see a patient die if it's what will lead to death. God forbid, if it's what may lead to death, you see patient die, you cannot do anything. Especially when you are the one that do home service. Be careful. Or maybe you went to one hospital and do 1 year or 2 years. This thing they do. They say that their name is not even in the register of nursing council of Nigeria. Your name is not there, and they're calling you nurse. You are doing like this. One day you enter trouble. You understand that this world is three stages. Your name is not in the nursing register of nursing council. You know, after this your training now, your name will register officially. That induction will do here. Your name will officially be in register of what? Pharmacy Council of what? Nigeria. But as a human being that you just go to one place, say they are doing one's hospital, they are learning nursing there, and they come out, they come out and be injecting people. You may be doing it and be escaping. One day they will call you, nurse, come to the home, come and give me set line in my house, come and give me IV. You rush because they say you charge 2,000 naira or 10,000. You will rush and go to the person's house, and you will see the person I call. Then you realize that's when you be asked, are you a nurse? You say you are a nurse. Then nursing council will say, we don't know this human being. The name is not in our register. We don't know her or we don't know him. Then you realize what you have done to yourself. Please let's be careful. Please let's be what? Careful. Some of you are in that league. Be careful. Be careful. All right. So let's continue. Can somebody check the meaning of thrombophlebitis? Thrombophlebitis. Because I know that if so you know.
A condition in which a blood clot causes inflammation.
Again.
A condition in which a blood clot in a vein causes inflammation.
So there's blood clots inside the what? Vein, and it causes pain. So there is risk of the disadvantage is that there's risk of what? Thrombophlebitis. Put it down, okay? Because you know that as you are injecting, you know anything that will slow movement of blood or disturb blood movement. Are we together? These blood vessels are tiny. Anything that will cause maybe slow movement of blood or distract the blood, what is it called? The intravenous injection can be in form of, it can be in ampoules, which you know, right? You know about, we discussed this in your first year. Ampoules, right? It can be in vials, right? Right? It can also be as what? Infusions, okay? In fusions, infusion bags, right? Where you set line and leave it over time, the thing will just be entering. Okay, so let's look at the next one. Let's look at subcutaneous. Let's look at subcutaneous. You call it you may see prescriptions. You see IV. It means what? Intra what? Venous. Then you see SC. It means what? Good. It means what? Subcutaneous. Okay. Now, hello. Any issue? Are you okay? Sorry. All right. Subcutaneous. So now, in this subcutaneous route of drug administration, A needle is inserted where? Into the fatty tissue below the what? Skin. Directly after the skin now, the fatty tissue below the skin, that's where the what? It's not inside the demiso. After the skin, you know the structure of your skin, right? After the skin, after the skin, inside, as immediately under the one you are seeing now, is subcutaneous what? Is what? Fatty tissue. That's where it is what? Injected. Yes, yes, under, beneath. Are we together? So now, when after injecting it there, that the drug will now do what? Seep and enter the what? Capillaries there. So from the capillaries now, they will now enter the systemic what? Circulation. Are we together? Are we together? Is deposited there under the skin, this fatty tissue there. They will seep and they enter the what? Capillaries there. Then from there, they will not enter the what? Systemic what? Circulation. So that's what happens. That's what happens. So now, actually, this one are normally used for mainly protein drugs like insulin. Like what? Insulin for what? For what? What is insulin used for? Regulation of what? Control of what? Blood sugar, right? Blood what? Sugar. So glucose level, okay? So for that, is an anti-diabetic, okay? Okay, is an anti what? Diabetic. So it's used for diabetic patient with what? Mainly type 1 diabetes. Don't worry, you will get there. Mainly what? Type 1 what? Diabetes. So see, these drugs are proteins. These drugs, something like this insulin is a protein. Once it finds its way into the what? Digestive system, it will be destroyed. Are we together? It will be what? Destroyed. That's why it's given through what? SC. So that it will, through the fatty this thing, it cannot enter the systemic what? Circulation. So it does it boycotts the what? The effect on what? Digestive what? Tract. Am I together? So you cannot take it what? Orally. One thing with this one is that you can self-administer it. Am I communicating? Yes, you can. Most of the diabetic patients that use it administer it themselves. Over time, they will start doing what? Administering it. True of us. Yes. If you have a diabetic patient that is on insulin, within short period of time, they learn how to do it, administer it. So it's self what? Administrable. So it's self-injection is possible. Because you don't need deep what? Penetration. You don't need what? Deep penetration. Please note that. You don't need what? Deep penetration. You don't need deep penetration. And another point I want to make here, that fat area is not that vascularized anyway. So because of that now, absorption is what? Slow. It's not that vascularized like other part of the body. Some part of the body, but because of that now, if you administer it, absorption is what? Slow. So the effect, the drug will have a prolonged what? Action over a long period of time because it will be absorbing gradually and the effect is maintained over a long what? Period. Because that area is not that what? You know what I mean by being more very, very as in highly vascularized. You know the meaning, right? When you say that something is an area of body is not vascularized, do you know the meaning? What is vascular? So, yes, what's the vascular system now? Blood vessels, right? So if you say that an area is vascularized, what do you mean? That there are a lot of capillaries there, blood vessels, capillaries there, that drug can enter and easily get to the what? Systemic circulation. But if it's less vascularized, it doesn't have much of this capillary, but it's there, but not that much. So absorption will be what? Slow, and at the same time, the drug will be entering slowly, because drug that will be appearing into the system slowly, because there's no much. Is when you have a lot of capillary that you can, all of them, because the drug are faced with a lot of capillary, they can move in and appear rapidly. True, of course. This one that they are sparse, not that highly vascularized. So the few that are there, only few of the drug will be entering over a long period of time. It will be entering steadily, but not that fast. It will be appearing. So it can, over a long period of time, maintain the blood sugar level for over a long period of time. The effect will not just fast. It will stop. No, it will take over a long period of time. So that's the point I'm trying to do. Make here. By saying that that place is less vascularized, and the absorption is what? Slow. So what is the implication? There is a prolonged action of the drug. We administer through what? SC, through subcutaneous route. Another point I want to make here is that small volume of the drug is administered. Small volume. That's why, who has seen insulin syringe here? Who has seen insulin syringe here? Very tiny, right? I ask a question, I don't know whether your attention is there. I ask who has seen insulin syringe. Good. Very tiny. It's tiny. Very tiny. You can even see up to 0 point something near the two of us. 0.1, 0.2 is there, 0.3 is there, 0.4 is there, 1 mil. Very tiny. Because that area requires just small volume of the drug is needed. Am I communicating? Small volume is needed. Maximum 2 mil. Maximum is 2 mil. So some tablets, known as implants, can be inserted where? In the watch. Can be inserted in the watch. That subcutaneous tissue. You know, subcutaneous is below the skin. I'm just giving you something, another thing that can be administered through the routes. Are we together? I'm trying to tell you something else that can be administered. I have mentioned insulin, right? And I explained what happened with insulin. I'm trying to point out something. I say that implant is a dosage form. It can be tablet, it can be capsule. We call it implants. They can be inserted inside that subcutaneous either by just incision. If you inside that the skin, it can be deposited there and do stitch again. Over a time, they will now be seep again and enter the bloodstream over a long period of time. Some people are looking for what to write. Instead of listening to understand what I'm saying. If you understand, you can put it in your own word. Well, but if you're looking for what to write, you'll be confused because I don't need to take notes. Sorry. Listen and understand, so you can put, because I can be telling myself, not saying it the same way. Two of us, you hear me saying it again up to 5 times, 5 different ways. The main thing is to understand it. So if you understand the point I'm making, I said that I made mention of insulin that can be injected using insulin syringe. And I asked if you have seen insulin syringe here. One person said yes, and I said that it's tiny. The bore is tiny, right? Now, and I said that I just mentioned something else that can be deposited in the subcutaneous area. I made mention of implants. And how can we put that? By incision. You know what incision? Abawa the skin. Mpowa in Igbo language. Mpowa your belly, kanya, or yellow your belly, right? You now insert it and stitch up again. Am I communicating? So they can be inside that to put in, not deep cord to inside so that you can deposit it in the what? Subcutaneous, that fatty area, and stitch up. The same way insulin seep and enter the capillaries, those one act over a long period of time. This implant can also do that and act over a long. By the time you start doing hormonal drugs, you understand much about these implants. Are we together? Are we together? Okay. Yes, now. That's why I say when you go into hormonal endocrine drugs, you understand that I don't want to start teaching endocrine drugs now. And we are talking about routes of drug what? Administration. Okay. Whether birth control, all those birth control pills, they're under what? Hormonal drug. True of us, they're under what? What is birth control? You are manipulating the hormones in the system. You are just either you mimic the hormone or you manipulate it. That's what birth control is all about. Your menstrual cycle is all about hormonal actions. True of us. True of us. And their birth control revolves around your what? Mainly around your what? Menstrual cycle. Unless you want to go and they remove whatever you want to remove or stitch whatever or stitch anatomically, but physiologically you can manipulate all those things. And but the issue there is after manipulating, your system will be scattered. Your cycle will become what? Scattered. That natural God-given cycle will be what? Scattered. That's the issue there. So if you are taking, know what you are doing, ask yourself a question: what am I even doing? Should I control the way I do the thing and when to do it? Or should I go and be manipulating? At the right time, when you come back to your natural instinct, you will not have it again. You start crying. What do I do? How do I go about it? Am I communicating? So, I'm not saying it's good. I'm not saying it's bad. The point I'm making is this: know what you are what doing. Some of you are some of single they have started even scattering their circle on their own now, even when they're not even married. Know what you are doing, so that when you start crying, what have I done to myself? Okay, let's continue. That's the side talk. Okay, now implant IMPLAN what T. This one now here is the tablet or capsule. It's a capsule or tablet. This one has. I just mentioned something else that can be through that way. I just mentioned. I'm not talking about injection now. I just mentioned what can be other things that can be deposited there. You know, we mentioned subcutaneous, so I see the opportunity to talk about some other things. Okay, because can a who on what can a making can a who be Okay, now what are the advantages? Basically, is self what admissible. True or false? Is self injection is what possible. Self injection is what possible. Of course, I mentioned other advantages, right? About the by cutting the what first pass, right? By cutting the what destruction by other enzymes, right? You know that these proteins are easily destroyed when they get to the stomach, right? Because of the condition of the stomach. So and the other things. So now, what are the disadvantages of this subcutaneous route? What are the disadvantages? Repeated injections can result in atrophy of the subcutaneous fat. Repeated injections. So repeating it all the time, keep repeated can cause what? Atrophy. You know what atrophy is?
No.
Look it up now. Atrophy. This is how it. I will not be saying everything. Look it up now. What is atrophy? See the spell it. Atrophy. Or if you want to go more that you can say what is atrophy of the subcutaneous tissue. It goes straight to that point. And you get a definition that has to do with that what you are explaining. What? Sorry. Is what?
Atrophy is a loss of fat tissue in a localized area of the body.
Can cause what?
Pitting.
Pitting.
Yes.
Pitting. And what?
Pitting, scaring and bombs.
Scaring. Scaring.
Yes.
As in SA to form a scar.
Yes.
Scar, right? Scaring. And bombs. Do you understand this?
Oh.
Again.
Okay. A fat atrophy is a loss of fat tissue in a right area of the body that can cause pitting, scaring, and then bombs.
Now, on a normal, fat listen, is it hard or soft?
It's soft.
So when it loses that consistency and becomes scar, okay, like a scar or even bump, that if you press it, it's not just fatty, you start seeing that it's becoming harder, right? That means that the tissue has what? Atrophied. Okay? Okay, am I committing? That's so. This repeated injection in that subcutaneous tissue can lead to the atrophy. Am I committing? That's the point you are trying to. It can lead to what? Atrophy. Yeah? It can lead to what? Atrophy. Of course, before you talk of getting to level of atrophy, there must be what? Irritation of the what? Subcutaneous layer. True of us. Before getting to level of atrophy, there must be what? Irritation of the subcutaneous tissue. True of us. There must be what? Irritation. So there is irritation of the what? Subcutaneous what? If the irritation is just the beginning, just like a warning. Now that this thing you are doing is disturbing me, you know that irritation is a response, true of us, to what you are doing to what a part of the body, right? Now, if you don't see the sign that is irritated, it can progress to what? Atrophy. Okay, so there's what? Irritation of the what? Even on a normal, there is what? Irritation of the what? Subcutaneous what? Issue. Of course, small volume like of maximum of 2 ml being administered is a disadvantage. It's a limitation. True of us. It's a limitation, right? I'm only reminding you of what we discussed. So I didn't say anything new. I am just reassuring or be sure that you are following. I say something about the only small volume can be what? Administered. And I also mentioned the maximum, which is what? 2 ml. And I'm not saying, I'm not trying to, have an agreement with you that small volume that is being administered of the maximum of what? 2 ml is a disadvantage. It's not. It's a disadvantage. It's a limitation. Two of us of what? Subcutaneous what? Route of drug administration. So small volume can be what? Administered. Okay. Now that's what for. I mentioned some drugs that can be. I talked about can be administered subcutaneous insulin, right? By injection. Then implant through what? By capsule incision and put it and cyst and this it will. So. Now next one is what? Intramuscular. IM. Intramuscular. IM. Now, when you need larger volumes, not to level of intravenous infusion, just larger volume, at least a bit higher volume, intramuscular is preferred to what? Subcutaneous. When you need a larger volume to compare with 2 ml, I'm not saying bigger, larger volume like 500 ml. When you need like 10 ml, okay, or 5 ml or thereabout, intramuscular is preferred to what? Subcutaneous. All things being what? Equal. Intramuscular is preferred. So when intramuscular is preferred to subcutaneous route when larger volumes of drug products are needed. Now, the muscle, this one now is being from the name intramuscular, is now being injected in the what? Muscle. So what it means is that it will pass the subcutaneous layer, right? And go down to the what? Muscle. So you need a longer what? Syringe, right? Needle. Not syringe. I mean not syringe, because the syringe harbors the what? Needle. It needs a longer needle to be able to penetrate and get to the what? The muscle. Because the muscle is inside. True of us. So you need that. If you're not careful, that's how you will inject intramuscular. If you're not careful, you just inject it at the subcutaneous level. If you're not careful, hope you know. And it can cause what? Seizure. Someone says seizure. Apple. Someone said apple. Okay, let's continue. When we go to the disadvantage, we will discuss that. Okay. All right. So I said that because the muscle lie below, deeper than subcutaneous, so you need a longer what? Needle. Very important. So which areas are these drugs being injected mainly? They are being injected into the deltoid muscles, gluteus maximus, rector femoris. I said, make I whine you a bit. Actually, deltoid muscle is here. That's the muscle of the upper arm. That's the deltoid. Deltoid muscles. Okay? Deltoid muscle. That's the muscle of the upper arm here. Then you can also, that's why you see them injected. True of us? Good. Then it can also be injected in the gluteus maximus. No, this is Latin. It's not gluteus. It's not English. It's gluteus. In Latin, you pronounce as spelled gluteus maximus. It's not gluteus. Gluteus, it's just English. They're just transforming to English. It is Latin word, okay? It's gluteus. You are going English language. I'm telling you Latin. I'm telling you Latin. In Latin language. This is Latin. Gluteus. It's not gluteus. Ike, ever. Your buttocks, okay? Yeah. That's why you see I am there, right? Now the next one is in the rectus. That's the thigh here. Thigh muscle, okay? Huh? What are you saying? Huh? Rectus femoris. Femoris from femur. Rectus femoris. Rectus, it's not rectus, please. In as much as I try to get the right pronunciation Latin, sometimes I will go to English, but the right thing is, this is how to pronounce it. It's a Latin, it's rectus femoris. In Latin, you pronounce as spelled. Those churches that use Latin words very well and understand that and understand what I'm saying. Is rectus femoris. It's not rectus. So that one is thigh muscle, thigh. Your thigh. So this is sites where you administer what? Mainly these three sites are the popular sites. Three of us mainly. Either they do it here, they do what? Our there are too much. If the two of them are scattered already, they can move to here or here. Two of us, depending on how long the injection Am I communicating? Good. But for children, children are mainly vaccinated here. Two of us. Two of us. Okay, so that is for the site of what? Intramuscular what? Injection. So now let's continue. Let's continue. Now, sometimes some site of this muscle, the rate of absorption they may differ. Sometimes some part of it may be highly vascularized. Some may not be. Some may be sparsely vascularized. Some may be highly. Some may be sparsely. You know what sparsely is? Sparsely. When something is sparsely, it is not that dense. Dense, okay. The actual opposite of sparse is dense. Sparse means that is here, is here, is here, is here, is not. But dense is that is highly compacted. There are a lot of that in here. Am I correct? So if it's sparsely vascularized, that means it's less vascularized. So if it's not vascularized, of course, I have explained what happens. Absorption will be what? Appearance in the bloodstream will be what? Slow. And it can be used, it can manipulate it as an advantage over for a prolonged, remember our prolonged release drug, remember? It can serve as a depot where you deposit it. That's why iron mainly serve as a depot. You can deposit it over some time, with time it will be sipping slowly and maintain continuous what? Appearance, okay, and action. Am I communicating? So iron doesn't appear in the bloodstream immediately. True of us, it will take something, but it will need to do what? Enter the capillaries around that site of injection and gradually start going. And now, so now let's continue. So I want to say that how quickly the drug is absorbed into the bloodstream depends in part on the supply to the muscle. The sparser the blood supply, the longer it takes for the drug to be what? Absorbed. Two of us have mentioned it. The sparsely now from sparsely. If it's sparsely vascularized, okay? So the sparser means what? The less supply, right? This is just, we are just playing with parts of speech here. Sparser. You're just playing with what? Parts of what? Speech. That's why so far we still use English as our medium of communication. You must study English language. Take it or leave until we start using Igbo language, our official communication. Your textbook is written in what? English language. You gotta do anything about it. Better go and learn English until we start seeing Igbo language. That's one physics. I don't know who has seen it before. The mistake I made is that I couldn't get the contact to get the book. That was the mistake. I saw it. I mean, one of my WhatsApp group. One WhatsApp group that there's physics Igbo. There's a physics textbook written in Igbo language. Yes, physics textbook written in Igbo language. Yes. So when will you get with the excuse me. Sorry, please, you guys, please, please study. I beg you, please study. Each time you fail, it's a stress to me. It's a really big stress. Please take whatever you are doing here very, very seriously. In this school, they face first year, they fail second year, they face final year, they even fail castle exam. You can repeat final year. There is no, so far, no game can and I know here. Unless my message was so far, and I know here, no game can here. You must do the right thing. Please study, I beg you. I am being stressed each time you fail. And if you take it well, your failure is not our fault. Because we do everything to make sure that you do what? You pass and pass well. You may feel today Saturday, why is this man stressing us? Because I want you to pass. I want you to know this. On a normal, because I know that I know my program. I know that once in September now I'll be divided. That's why I'm pushing so we can do as much as possible before that time. Nothing prevents me from staying in my house and be sleeping and going to go and rest. Whether we finish the outline or not, I will take to go and read up. If I like, so I won't even take to go and read up. I will set what I thought. You may pass, but you don't know anything. Is that what you want? Is it okay like that? So please, don't see it as this man is suffering. I'm not suffering you. Look at me from Monday to Saturday, I'm here. 7:30, I'm here. Do you think it's easy on me? It's not. But if I'm into something, I do it well. If I'm tired of that and I'll leave it, that's who I am. If I want to do something, I'll do it well. If I don't want to do it, I'll leave it. They're nothing like this. I'll leave it and go my way. So far I've signed to do this, it should be done well. So I'm doing everything possible to ensure that I will cover this outline. This outline is big. By the time we start going, you understand better. There are a lot of things to cover. So please, don't stress me. If you do the right thing and pass well, you will not stress me. If you fail, you start call up and down, start discussing up and down. Discussion, what do we do? How do we go? There's nothing you can do about it. If you fail, you fail. I don't know what to do about it. Don't exist in my dictionary. If you fail, do what? You fail. And even that failure is not even the end. It's an opportunity for you to correct your what? Mistake. It's an opportunity for you to correct your mistake. It's not that you have that is no. But do not be in such position. It's not a good thing. But if you are there, you see it as an opportunity to do what? Do better. So please, sorry for the distraction this morning. If you don't listen, it to look as if you don't want to. You don't care. You are second year now, right? You've seen some second years that have joined you people, right? You've seen some older second year that are joining people. You've seen them, and more are coming. That is, if their party would allow them to come, there are more will say come. Some will decide to run away, go. It's normal. We've seen it here on the basis. But it's always good to take the humble way, unless you don't have the money to pay school fees again. It's a effect not together. I'm not competing. But please don't put yourself in that situation. It's devastating. But you have no choice. This is a healthcare profession. It's healthcare. You don't give chances. So these are people that will take care of people's life in the near future. You don't give chances at all. You don't give chances. And that's why we give zero tolerance to. If I catch you in exam this night, I don't mess it, because you need to know it. You need to show that you know it. At least, if not for anything, at least you be able to put it in your head. Even if you crammed it, there are some things that will still be retained when others disappeared. True of us, but not even being able to even put it in your head. And that is where it's even a problem. You cannot cram, you cannot understand. Then what are you doing? You should do one now. It's not you. You do one. So please let us take what we are doing is serious. Where did we even stop before I was distracted? I think we are done with IM, right? Are we done with IM? We're not done with IM. Okay, yes, I remember that. So and I already explained the meaning of spasa now. Spasa is from where? Sparse, right? Sparsely. I thought that this is just we are playing with what? Parts of speech. Sparser. Sparse is just adjective, right? Sparse is what? Adjective. Sparsely is what? Adverb. True of us? Uh-huh. So we're just playing. We are talking about when if the blood vessel is not that much around that area, okay, then you find out that the absorption will be what? Slow, right? To be slow, and it is you can take the advantage for a drug you want its release to be what? Prolonged. Profos. Yes. Because when we are treating intravenous route, there's something I said. I said that if you inject intravenously, of course, immediately the drug is entering the system. Note something. Once the drug enters the bloodstream, it will start acting. Okay? So any manipulation you are doing will be to manipulate at the point of absorption. You manipulate the drug. You manipulate the medicine now, not the drug. Am I completing? You cannot manipulate the drug. Once it enters the bloodstream, it will start acting. So what you manipulate is the dosage form, is the medicine. You now know how to go about it so that you can modify the release, either delay it before it get to the what? Systemic circulation. So that's why I said that in injection, in IV is delivering the drug directly into the what? The system. And it will act fast and end. To avoid that, you manipulate how you do what? Infuse it slowly so that it will be maintained continuously. Am I communicating? That's it. So now, when you come to IM now, if that area is sparsely vascularized, is also an advantage. You can deposit large volume there, and gradually it will release. It will enter in the systemic circulation over a long period of what? Time. Now that's the point I was trying to make there before I was distracted. So now so it depends on where the sparser the blood supply, the longer it takes for drug to be what? Be absorbed. Okay? It is less what? Painful. It is less what? Painful. To compare with what? True of us? Yes. Where the fear lies is when they are about to do it psychologically. You start imagining the pain. You squeeze your gluteus maximum. But once the needle enters, you relax. True of us? True of us? Once the needle enters, you just relax and they will remove it. You won't even feel it. It's at the point of end. That psychology. Easy to pain you. But there are some people that will do it. That's why people now have this assumption that this person's hand is painful. This person's hand is not painful. Like maybe the scale, how they do what? Penetrate it, how they do it will now cause the pain. But there are people that once they inject you, there must be abscess. Maybe I don't know if they don't know the scales on how to do it. Am I communicating? Once they inject, you must feel that pain. But there's pain, oh, but there is less. I didn't say it's not painful. Oh. I say it's less. That's the point. Of course, you rarely self-administer it because of the penetration. Even though some people can do that, I hope you know, on their own. Are you aware? But it's rare. So generally, the self-administration is often what impracticable because of the what deep penetration. I made mention of depot preparation. Drugs like oily drugs. Oily solution can be formulated as what? So can be injected intramuscular. Oily solutions. Even suspensions, aqueous suspensions can be injected via intramuscular routes. Okay, so route. Okay, let's look at summary of advantages and disadvantages summary. In addition to the ones you can pick up from what I said before, the absorption is relatively uniform. The absorption is what? Relatively what? Uniform. To compare with oral route that is erratic. True of us, but the absorption is relatively uniform. And it has rapid onset of what? Action. But less rapid than what? IV, right? More rapid than what? Other, maybe oral routes, enteral routes, oral route specifically. But it has rapid onset of action. Of course, you bypass what? GI effect. True of us, you bypass GI effect and even first pass what? Effect. Bypass GI effect and even first pass what? Effect. Disadvantage is that volumes above 110 ml cannot be what? Administered. So larger doses, the ones above 10 ml. So it's also what? A disadvantage. The second disadvantage is that depending on what on the nature of the how it is injected and other factors, there's this local pain you experience. There's pain. That's why they use lidocaine. Hope you know. Yes. It's only Uche that is answering. I understand. There's always pain. There's pain, but not that it's much. It's more than you have in what I mean. There's pain there. That's why they use lidocaine. So there's local pain, localized pain, and there's what? Tendency for what? Abscess. There's tendency for abscess. Apple. Couldn't apple. Child, okay, you might have abscess. That's why you are here. That's why you are here. That's why you are here. Abscess. Apple. I have apple in Igbo now. You must see, apple is of different source. It's one of the apples. If you hit your head here, there can be apple. So that one is one of the apples. So now depending, that's why you should be careful. Depending, there can be nerve damage. There's this nerve they call, I think that should be the largest one. I think is what is, if not the largest nerve in the body. Apart from the spinal cord. Hope you know that spinal cord is a bundle of nerves. Hope you know. Yeah, but once it's divided and enter, we call it sciatic nerve. Sciatic nerve. The major nerve that supply, you know, that this is your waist. For those that have figure 8, this is your waist. For those that have figure 8. Not those that did their bum. I mean natural figure 8. Now, Now, I may not get it correctly, but I just want to do a schematic with it. So this nerve from the spinal cord, the nerve comes out. Is the major nerve that supply the lower limb. This from here down your leg, from your waist down to your leg. We call it sciatic nerve. Sciatic nerve. Sciatic. SCIATIC. Sciatic nerve. Lower limb. Lower limb. Once again. Are you in this class? In the music I see that now I know this class. You know what another class? Yeah, yeah. That class is on here. After like 2 seconds, 2 4. Hey, actually goes. We go your question. Hey, okay. Ask your own. Ask your own. Good. Let me answer her own now. I've answered the full zone. Let me answer her own. I said lower limb from here. Here, this is your lower limb. Lower limb. In anatomy, we call it what? Lower limb. This is upper limb. Upper limb. This is your upper limb. This is your lower limb. Okay? Your leg down. From here to your leg down is lower limb. So it's the major nerves that leave the spinal cord to enter all these places supplied by this nerve. We call it what? Sciatic nerve. That's why they say that if you maybe the small boy or the man went to one nurse. I don't know whether I don't know where the nurse was trained, and because a nurse that did not do anatomy, I don't know what he did. So people that go to one place, they say that they are learning nurse. I don't know. They know nothing about human body.
I want to be a nurse.
They know nothing about human body. Let's be sincere with you. As my church. Yes. They know nothing about human body. It's in the anatomy and physiology that you'll be told that about sciatic nerve. You know exactly. You study anatomy. You study nerves. If you leave the spinal cord via the spinal canal and enter the lower limb, from here all the muscles here, everything going, everything nervous here is supplied from that what? Sciatic nerve. It start dividing, innervating different muscles and the other structures there. Now, there is this thing they'll tell you, you divide the buttocks into 4 quadrants. 1, 2. 1, 2. This sciatic nerve doesn't, unless there is an issue with an, there will so that we have an anatomical differences. Some maybe some structure that are supposed to pass through this place will not go. It happens once in a while, but that is rare. This is the first quadrant. First, second, right? Which is the second? Which is tell me? First, second. Which one is third? Third, fourth. Now, I call it inner, upper, outer, lower inner, lower outer. This sciatic nerve doesn't cross this side. Sciatic nerve cross, it doesn't enter here. So there is this training they will tell you if you want to inject upper, left, outer quadrant, you inject here. So as to escape this sciatic nerve, you make it get drawn into the door now this sciatic nerve. The whole lower limb is gone. Open at the damage did too much. Upon one. So if you let's assume a pump, a tap or a pipe is supplying water, you have about 15 million pumps here. People are enjoying tap inside this room, and you go outside and target that target that major part that supply and go and block it. We water flow inside it. So the major nerves that that control movement and other activities here, you go and deal with it with your network because you do not know about it. This whole everything here, the muscle, everything here will not. You start experiencing muscle waste. You must have heard or seen that maybe a child or someone was taken to be injected. That's what happened. Am I communicating? Yeah. So that's why if you now want to inject, if you are using here, you run away from it. But some of these people may not be, this thing may not be explained in detail like this. They just say, okay, do well, you use your eye dividing into 4. Use your soak your wool in the spirit, and that is cha. Then do there. Maybe they will do cha. The spirit may dry off. Because they don't know exactly why and what actually happened. They go like sway here. Although it's no longer common these days anyway. It's no longer, but it's still happening. It's still happening. Yes, even though it's not your training, hope you know. Injection is not your training, but at least you should know about it so that you know exactly what you are doing. In case you are there, someone want to do nonsense, stop. Where did you train? I think I trained in Gede Hospital. See, I wait. God bless you. God bless you. Chile, Yakaina. Okay, what do you ask a question? How do you know how to divide it? That's what I've been explaining here since for the past 20 minutes. And I have really explained the reason how to do. I have explained that. I told you that's why you study anatomy. Each of the structures in the body have their parts. They have where they are located. They have their location. How do you know that? How do you know that your stomach is here? Is it here or here? Where is the esophagus? It's okay. Let me start question now. Where is your esophagus? How do you know?
Because they said it.
They said it. Okay. So it's because the anatomy has been studied. At least I have an opportunity to see where they dissect. I've an opportunity to be in an anatomy lab. Where apart from what textbook is saying, I have an opportunity to be in an anatomy lab by my training to see where to dissect human body to the end, dissect it, use it for practical. A full human being will start from the practical, from the head. You study the head from the head to the toe. You see all these structures, see how they look like, see all these things, touch it, open inside, see everything inside. Now, your anatomy will tell you this is where it is. So why is your esophagus not here? Because the anatomy has said so. And if the anatomy says so, those that have seen it have captured it in images. If you want it live, you see it live picture of it. Google it, is there. If you want to see the graphic design, you see it. So that's how we know. So that's how we know that it doesn't run here. Remember I made a point. I told you sometimes there might be anatomical variations in small percentage of people. Sometimes it can happen. There may be a shift. It happens, but it's not that common. So if unfortunately such person is one that we have this thing running here, I mean puncture it, we have tried, it's not your fault. There's nothing else you can do. And it's not your fault. Am I coming to you? Because you have actually targeted you here. You should target. But it's different from not knowing. That is different. Hope you know. And if anything comes up and there is serious investigation that could lead to serious investigation, and they find out that there's a variation, it's not your fault. Am I communicating? That's what I'm making. So that's how we know. Okay? Hello? So, this is from a biology class, right? Yeah, I just mentioned it. Don't worry. Don't worry. When you enter an anatomy class, you can talk about that. If we keep discussing this, I just mentioned it. I just want to share with you my experience here and my knowledge here. I'm not, I like going to something else to you to explain something. So at this level, I think we'll stop here.
Yes.
Okay? There are other things involved. I don't want us to start going into that. Okay? So I think we are we? Let me see if we are done with. If I have exerted a point, okay, nerve damage can occur if you're not careful. I think that's the last disadvantage. It can lead to nerve damage if you're not careful. Okay, so let's go to the next route. Remember, we are still on the injection, right? The injection part of the what? Parenteral, right? Yeah. So let's look at intrafecal. Intrafecal. This marker is not markering. Intrafecal. It's TH. Intrafecal. It's not te, it's fe. Alright, let's go. So it's not te. It's what? Two of us. Is it this or this? Is it this or this? It's not there. It's not vecal. It's fecal. Please, let's continue. We are not in English class. Let's continue. Okay, so here actually this happens where in the spinal vertebral column, spinal canal, spinal cord, meninges. This is where this happens. Just that vertebral column, that is where the target is. Anything you are injecting around that area, the spinal cord, through the spinal canal, into the meninges and the spinal cord. You know that spinal cord is covered by meninges. That is what covers the spinal cord and the brain. So inside the meninges, through the spinal canal to the spinal cord, anything that's happening there is called what? Intrathecal route. So let's go. So here the needle is inserted between, the spinal canal. Remember you have vertebrae in your biology that are the vertebrae. If you remember the structures of your vertebrae in your okay, you still do it in your anatomy. In your biology, you study the vertebrae. The vertebral column is just bones, vertebrae that are arranged like this, packed like this. There's this intravertebral disc between them too. That's why you can do like this. If your intravertebral disc has issue, you cannot do like this. Two of us. That's why you can bend. Now, this inside that, each of these vertebrae, they have a hole inside them called what? Spinal canal. So when they come together, that hole will form a ball. That's where the spinal cord, when they leave through the brain, medulla oblongata, to go down and enter and pass through that what? canal. This is spinal cord. The spinal cord is covered by what? Meninges. Now, when you now go down from there, this is from the spinal cord that different nerves are coming out to start supplying, innervating different parts of the body. Am I communicating? Now, anything you are injecting there is what? Intrathecal. So, and here a needle is inserted between two vertebrae. I talked about the vertebrae, right? In the lower spine and into the space around the spinal cord. That is spinal. There's this space around the spinal cord. Through they can now inject the what? Whatever drug they want to inject. So basically, the drug is injected into the what? Spinal canal. Basically. Now here, anesthetics actually, before you can do that, anesthetics are first of all administered to numb the what area, so you don't feel the pain what much because it's painful. Okay, so you don't feel the pain what much. Anesthetics is what applied, is administered first at the injection what site. So what is the purpose of this? Aboga Anna. Anesthesia. Why confused? What happened? But you have this in your material, is there? What are all right, okay, don't ask a question. Let me ask a question. Let me explain. Okay, below, you just say below? No, I don't say below. I say into the space around the spinal cord. I did not say below. Lower spine is here now, right? So are we together? Yes, sir. So what do we need this route for? What do we use it for? First, it is used to do what? Produce rapid or local effects on the what? Brain, spinal cord, or layers or meninges. I think I told you that meninges covers the what? The spinal cord and brain. So if you want to now establish a rapid effect around this area, it is what? Through this what? Intrathecal. So it's used to treat infections around this place. Even some analgesics like morphine can also be given through this way. So when a patient, maybe if there is infection, what is meningitis? What is meningitis? What is meningitis? Inflammation of what? The meninges. God bless you. So it can be caused by pathogens. Hope you know. It can be caused by what? Pathogens. Yes, it can be caused by a lot of ways can cause it, but it can be caused by what? Pathogens. So if you want to treat infections of the meninges and you can use what? Through intrathecal, you can achieve that. You can do what? Achieve that. Okay, so and sometimes if your target is to introduce drug directly into the cerebrospinal fluid, you can do that. Cerebrospinal fluid. It can be used to administer drug directly into the CSF, cerebrospinal fluid. What are the advantages? I think I have mentioned the advantage before, but let me just put it in summary way. Cerebrospinal fluid. Cerebrospinal fluid. Cerebrospinal fluid. So what are the advantages? I think I mentioned the advantage, but let me just put it in summary form. Now the drugs act directly. The drugs here, the advantage is that the drugs act directly on the where? meninges and the what? CNS, central nervous system. The drug acts directly on the meninges and what? Central nervous system. That's an advantage. And also another advantage is that the drug bypasses what? The drug bypasses what? That's what blood-brain barrier (BBB). Blood-brain barrier (BBB). It also the drug also bypasses blood cerebrospinal fluid (CSF) barrier. So the drug can bypass blood brain barrier (BB). Just know that, or blood simply, or you can simply say blood CSF what? CSF means what? Anyone what they call it is allowed. So what are the disadvantages? Expertise is needed. You must be an expert in that before you can do that. It's not what anybody can do. It's not your everyday Chioma come and buy me injection. No. It's not your everyday Chioma come and buy me injection. No. So you must be an expert in that before you can do that. It's not what anybody can just do. Any nurse can just do. Okay. So it needs expertise. So expertise is needed, required. So where do you now see such expertise? Money is involved. Two of us. Money is what? Involved. To get such what? Money is, and it's painful. That's why they use anesthetic first to numb. Do you know why you feel pain?
Yeah.
Because of what?
The nerve.
Yes. So now, if you feel pain, listen carefully. If you feel pain, they want you ever this place. You know that before the nerves divide, the nerve that leaves the spinal cord around this, there's this. Apart from the sciatic nerve that comes, there's this thing they call brachial plexus. There's an interwing of nerve that leaves this place to enter this place. Okay, someone browse brachial plexus, you see it. Just browse structure of brachial plexus. Just do it now. Brachial, see it here. Brachial plexus. Just the structure, just the image, please. Just Google the image. You see what I'm talking about. Just image of brachial plexus. Brachial. Brachial, BRACHIAL, then PLEXUS. Can you see the image?
Yes.
What is there? How is it like?
Branches.
From near to that enters this upper arm. Now, to that place now, all the nerves, after this little whole thing now, they will not enter here. By the time they start, the nerves enter here, it will divide. The one that will be here with just small nerves, right? Nerve endings, right? Small nerve endings that will be here. Now, if these small nerve endings, listen carefully. If this small nerve that's here, just because you pinch here, you can feel the pain. Or fall go to right, get needle, punch here, you cry. Now tell me, when you now go to the main roots, which is the spinal cord, to go and tell me how the pain will look like. Very, very painful. That's why they use anesthetic first to numb. I think I mentioned it. To numb the what? So you don't feel the pain. So it's very, very, without this anesthetic, it's very, very painful. Okay. Kanaba. Intrathecal. No. That's spinal cord. Ventral column. Now, so what was that? You nasi, hey. Imagine the person has accident and break his spinal cord. You don't break spinal cord. What you break is what? The vertebra. Hey. What you break is the what? The vertebral column. The vertebral column protects the spinal cord. So if you break the vertebral cord, there may be a puncture, a damage on the spinal cord. And if there's damage on the spinal cord, what it means that the root has been tamped, the main thing that supply all those that innervate everything. So what if you open any part of that spinal cord that has issues, from that place down, we're paralyzed. Because no nerve, because it's from that point that the messages, coordination, nervous coordination, cannot go down again to that area. You become a vegetable there. Am I communicating? What's that? So please, let's continue. I think we are done. Are we done with this? I think we are done with this. Interpreter, right? Now let's go to the next one. Hey, wait now. She know I went up for like 20 minutes. She know. Please now. Are you hungry? Alright, so in the next class, I wait now. When I wait, come down now. Go back first, please. Alright, in the next class, we'll start from where? We'll start from, we are not done with the injection routes. No, in our next class, we'll start from intra-arterial in our next class. Don't go, calm down. I know what I'm saying. Thank you very much for your attention. See you next time.